this exciting panel and really innovative companies.
Yeah.
Next.
Welcome, Mark.
Thanks, everyone.
We're the end of the day. So this is when we're the last panel, that means we're going to have to really do some pretty incredible things. But you guys are pretty lucky because we have 9 really, really good companies here. And also, of course, you've got a few pretty amazing panelists. Not me, but some of the other folks that I'm about to introduce. I'm Mark Goldstein. I'm chairman of UCSF Health Hub. We recently put on the UCSF Health Awards, and it got me close to 1,000 amazing next generation digital health startups and growing companies and actually mature companies. Bambi and Arshana picked 9 really, really good ones today. And so we're going to be able to hear from these 9 companies really quickly. They're going to give us a quick little pitch who they are. And then we're doing a roundtable. So we're all going to talk, and you're going to have 4 or 5 of us talk to the companies. We're going to take a few questions. We are going to interrupt these guys. This is not a venture capital pitch thing. This is something that basically the companies, we really want to tease out why you guys are amazing. Why are you guys representing the next generation of primary care? This is like the 3rd inning, the 4th inning now of primary care. This isn't the first generation. And why were you picked? Why are you guys so great? So really with that, again, I'm Mark Goldstein, UCSF Health Hub. I'm also a venture capitalist by day at Builders VC. And really with that, Hubert, I'm going to turn it over to you. Why don't you introduce yourself?
Hey guys, Hubert Zajicek. I'm in Dallas, Texas. I run Health Wildcatters. I need to download the background. Obviously, I'm a non-compliant panel member, but should be able to do that without getting too distracted. Health Wildcatters is a healthcare seed accelerator. So agnostic within healthcare, but with a heavy tilt towards digital health and medical devices.
Great. Ryan, why don't you introduce yourself?
Hi, good afternoon, everybody. Ryan Helon. I'm with a firm called Rev1 Ventures in Columbus, Ohio. We're a startup studio and seed and early stage fund manager. We spend a substantial amount of our time in healthcare, digital health, healthcare IT, and life sciences, among other industry sectors. Pleasure to be with you all.
Perfect. David, your turn.
Yeah, hi, Dave Kereiakes. I'm a partner with Providence Ventures. We invest on behalf of Providence St. Joseph Health, a large integrated delivery network based in the West Coast. I have invested in a bunch of companies that enable a consumer within healthcare reduce access or enable access, reduce barriers and friction.
Perfect. Good. Bambi, do you want me to go through them, or do you want to run through the list? What would you prefer?
Oh, this is your show.
Oh, okay.
Your show, Mark.
Great. Okay, so here we go. We've got 9 companies. We're going to start. We're going to start up with CrowdHealth. Now, each of the companies is going to get up to 120 seconds to really give you a sense of why they're great, what their superpower is, why they're the next generation of primary care, and they're going to run right through it. And then we're going to basically hit them up with questions. CrowdHealth, you guys get to go first. Uh-oh. Well, you know what? You guys are going to go second. So how about Bone Health? And I know you're there because I see you, Laura.
Hi, thanks very much for giving me the opportunity to present. Let me share my screen. At Bone Health, we are passionate about solving one of the most important public health issues that exists in our country, and it's that of low bone density. So half of all women over the age of 50 will suffer a fracture from osteoporosis, and this is more than heart attack, stroke, and breast cancer combined. So it's an incredibly common problem for women, and also 1 in 4 men have this as well. Fractures can be deadly. 20% of people who have a hip fracture don't survive a year, and spine fractures are very debilitating. And the reason why this is such a big problem is it's a disease of aging. We're living longer, we're less active. And this is the decline of the average American woman's bone density. And what you see is the average American woman develops osteopenia in her 50s and osteoporosis in her 60s. And the current treatment options are just completely inadequate. There are some pharmacological treatments, but they are not used until someone already has osteoporosis. There's no like Lipitor or metformin equivalent for osteoporosis. Calcium and vitamin D doesn't help unless you're deficient. The one thing that has been shown to help is high impact exercise, but most of these patients can't or won't do that. And by the way, high impact does not include walking. It has to be sort of a jogging to stimulate the bones. Fortunately, there's a body of evidence done primarily by NASA that showed that whole body vibration improved bone density. But one of the challenges is, although the effectiveness was good, it only works if you comply, and these platforms are difficult to use and expensive. And so the founders of Bone Health Technologies invented the OsteoBoost, which takes the precise vibration from the whole body vibration platforms, which was proven there, and put it in a convenient and comfortable belt form factor, which makes it easy to use. You strap it on, go about your walk or your chores, and it actually feels good. It feels like a massage. And most importantly, it targets the vibration to the most vulnerable part of the anatomy, the hip and lumbar spine. We're in the middle of a NIH-funded clinical trial, and what we're seeing from our HeyRenee data is excellent efficacy. Our patients are losing bone at half the rate. Our FDA path has been de-risked. We were awarded breakthrough device designation. Our endpoints were showing good effectiveness from our interim data. We have a de novo clearance path, and we have calibration as a key device feature where we calibrate the actual delivery based on an accelerometer.
And 20 more seconds, Laura.
And so just what does this mean in terms of back to our bone trajectory is that we can delay the onset of osteoporosis by more than 20 years and reduce the risk of fracture 2% for every 1% improvement in bone density. We have a strong team of experienced medical device and tech entrepreneurs, and we're super excited about the scientific advisors that are working with the company and conducting our clinical trials. They're literally the top osteoporosis experts in the country. We've gotten over 4.7 million of NIH grants, as well as a number of prestigious prizes.
Great. Thank you. So that's great. So one quick question before. So why are you disrupting primary care?
Well, primary care right now is doing very little about osteoporosis. So it's a very small percentage of our patients that are covered by specialists, endocrinologists, or rheumatologists, and compliance with medication is low. So, all of these women are in primary care. They're seeing their internist, their OBGYN, they're developing osteopenia, and they're essentially told, well, make sure you're getting enough calcium and exercise, and we'll look at this again in 10 or 15 years.
Okay, great. I get it. Andy, are you here?
Here. Sorry, I was on mute.
Story? Okay, here you go.
Yeah. CrowdHealth, we're out of Austin, Texas. We were founded earlier this year, and we're providing the people with a set of tools that we believe allow them to viably and safely pay for their healthcare expenses outside of traditional health insurance. So in fact, my wife, my two girls, and I have been uninsured for 2 years. We've used these tools, couldn't be happier with our healthcare experience. And simply, we believe that paying cash at the point of sale alleviates doctors from some of the administrative burdens of health insurance, and that results in significant savings. And so I may be the only one on this panel, maybe the only one in this virtual room who will actually advocate for more people being uninsured instead of fewer people being uninsured. I'm happy to defend that position. And as for funding, we raised $6 million seed round led by Next Coast Venture Partners and Activate Venture Partners in April, and we launched in October.
Nice. Great pitch. Mark, let's hear from Decoded Health.
Sure. Decoded Health is a clinical hyperautomation platform that scales physicians and clinical providers by at least 10x. And I just want to take a step back. We've heard a lot today, really great session. I've heard a lot about longitudinal healthcare, about patient engagement, about many things that will improve primary care. I'd like to also add to that health equity, but largely none of that is going to be achievable unless we solve the very critical problem of physician and staff shortages. I mean, what we've done, and not to be too controversial, but I think what we've done is we've done the medical equivalent of adding a drive-through to a Starbucks, right? We can see more we can definitely increase the access points, but we haven't solved for access. And the only way we're going to do that is by creating more physician supply. Unfortunately, we can't just magically create more physicians. They take 8 years to develop, and then they have to go through residency. So what Decoded Health has done is we are addressing the massive shortage of physicians and the growing inequity that's resulting from that by creating autonomous, virtual, clinically trained AI physician extension teams. These are autonomous, artificially intelligent, clinically trained, medically knowledgeable, task-oriented services that can largely do many of the things that a physician would do in a clinical environment, such as perform a clinical patient interview, HPI, review of systems in complete natural language, interrogate an EHR, come up with an explainable differential and explain that to a physician, do patient follow-up, pen orders into the EHR that are relevant to that physician, making sure that the physician has all of the critical information that's going to be required for them to make a decision quickly and efficiently that's going to enable them to see a much larger patient population, at the same time develop deeper relationships with their patient, and ultimately improve access to care and affordability.
Great. Fantastic. Rachael, let's hear about HealthNxt.
Hi, everybody. Thanks for the opportunity. So HealthNxt is a virtual care platform built for enterprises, so mostly hospitals and health systems. What we do with our platform is consolidate and combine all of the disparate components of virtual care that are out there today that lead to a fragmented experience for a patient. We do this through the use of different types of interoperability, really thinking about at the core and at the center of everything that we do, the patient experience across their entire patient journey. We know that for patients, it's extremely difficult for them to understand from point A to point Z how to really go through their entire experience as a patient, either initially getting access to a physician or the follow-up type of care or remembering to take their medications or all those sorts of things. We know that there are a tremendous number of point solutions, a lot of them we've heard about today, that administrators of hospitals and health systems need to try to wade through and figure out how are they providing those capabilities to their patient population in a way that makes sense and can be connected. Because right now, the majority of those experiences, while they may be good for that patient in that silo of whatever the disease state or condition or business unit that they're working with at that point in time, it is not connected throughout their entire journey. So what we do with HealthNxt is really bring all those pieces together, connected with the EHR, really working to preserve the clinical workflow to the greatest extent possible while supporting the patient through a single pane of glass. So providing, a mobile application and a web version of the tool that is white labeled and branded for the hospital or health system to help them with their own branding, but really combining all those disparate components. A couple of successes that we've had so far. We spun out, we were incubated with inside of Tech Mahindra, spun out into our own company over the summer. And we've been working with several large health systems around the country. We've done a lot of work with COVID and remote monitoring for COVID patients. So have some great initial use cases and case studies about how we've been able to implement within large health systems, stand up very quickly and show results very quickly as well. So, one of our greatest crowning achievements, and actually the CIO of this health system won the Chime Innovator of the Year award this year based on the results that we were able to achieve from this, but stood up a COVID rapid response type of remote monitoring capability, had 140 patients on the platform within the first 30 days. And we're actually able to help them with the huge mortality issue that they were facing amongst their transplant population.
Great. Excellent. That sounds great. I got some questions for you later. Okay, Nick, this is your second time around in healthcare. Let's hear about HeyRenee.
Thank you, Mark. Thank you, Bambi. Thank you to UC San Francisco Health Hub and to Vader TV for having me. I cannot be more excited about a session that is called Primary Care and the New Healthcare Quarterback. At Heal, my previous company 7 years ago that I founded, we reinvented primary care through home-centric care, doctor house calls, and telehealth. so that a patient wasn't worried about the modality of care, just getting great care, right? And with the new company, HeyRenee, that my wife and I started 3 years ago, she's a Renee of HeyRenee. I'm sorry, 3 months ago. She's a Renee of HeyRenee. We are reinventing what the medical quarterback is. And the most important thing to say about that is that we don't think the primary care doctor is the quarterback of your care, right? Right now, there isn't a great quarterback. It's like playing a football game with a play caller and no quarterback and a team trying to scramble to make it work. There's no one bringing it all together. The best attempts are being made by unpaid caretakers, which are family members that have an economic cost to the US economy of $650 billion a year. 43% of American adults are now helping care for loved ones other than their own children, the healthcare needs of loved ones, and they're unqualified. They don't know how to do it. And 75% of those people themselves get depression or anxiety symptoms because they're so overwhelmed by how to take care of patients. HeyRenee is your new quarterback. We're the concierge for your care. The doctor is the play caller. This is what you need to do, the architect, if you will. Our care concierge takes your doctor's instructions, all of them from all your providers, and implements them by integrating a myriad disconnected providers, point solutions, and partners to all work together for more data-driven, proactive, unified care delivery. Our customers, our payers, and health systems who want to lower costs. Our end users are older, underserved, and polychronic Americans who need this kind of help more than anyone else, and their caretakers, who are often exasperated adults like all of us. We've raised $3.8 million in seed capital. We'll be coming out in January for Series A. And we're in a pilot right now, and I'll share one data point from that pilot, which is people, for polychronic Americans over the age of 65, their own perception of their health status is a net promoter of negative 26. 2 weeks after using HeyRenee, that perception of their health status increases from negative 26 to plus 41 in just 2 weeks, because people need that quarterback, and that's what HeyRenee is. Thank you, everyone.
Great. Appreciate it, Nick. Okay, Anthony from Insiteflow. Let's hear the story.
Yeah, great. Nice to meet you all. Appreciate you having us. I'm going to share some slides really quickly. So we're actually a workflow interoperability platform. So what does that mean? We're at the intersection of all these great analytic solutions that already exist in the industry, and where the primary care doc is spending all day and increasingly an hour or more at night, which is in their EHR. So what does that mean? What we do is we take those third-party solutions and we make them accessible, one click, and you're instantly signed on, no need for an ID or password. It's in an embedded browser that's all safe and HIPAA compliant. And then you can interact with that third-party solution. And then when you make a decision as the primary care doc, we'll write that decision into your electronic health record. And so we're EHR agnostic, we're use case agnostic. These are just some examples here on the right, but by no means is it limited to that. And then here's 3 examples of actual customers that already had existing solutions around documentation integrity and clinical surveillance and risk adjustment. And what we did is we allowed their clinicians and their staff to really be empowered at that point of care in their EHR and at other key decision points to really improve outcomes and financial results. And so what that's doing is really unlocking this missing piece in the quadruple aim, which is making a better clinician experience. We did this before as well. So inside the advisory board, I actually worked with Rachael back when we were inside the advisory board, and we built a solution for risk adjusted reimbursement where we ran analytics and put the output of the analytics into the EHR workflow. And then after work had this idea, hey, we can unbundle the analytics and start to serve the rest of the industry by integrating third-party solutions. What differentiates us is that we actually write our decisions into the EHRs. There's other ribbon companies that don't do that. We filed our patent for all of this. And then we're really about optimizing our customer solutions, not competing with them. And then here's just a quick example for one of our customers recently where we deployed an app, and within that hospital, 80% of the physicians were using it. We've seen similar results where it's 80, 90% of primary care docs using it as well. So that's the quick story on Insiteflow.
Great, fantastic. Next up, we have Benjamin Alouf from Limbix Health.
Hi, how are you? Thanks for having me on here. I'm going to share my screen and All right, you guys all see it?
Yeah,
Okay, great. So at Limbix Health, we're working to be the first digital treatment for adolescent depression. You know, the COVID.
Benjamin, I'm not so sure we're seeing
I'm
the
not,
screen.
yeah, it didn't
Oh.
come through.
Yeah, let's try it again.
Oh. Sorry.
Uh-oh. There you go.
Now?
Yes.
Okay. All right. Adolescent depression is now it's an epidemic within a pandemic. The American Academy of Pediatrics and the American College of Childhood and Adolescent Psychiatry have declared it a national emergency. Cases of depression are up. Suicide attempts are up. Suicide is the second leading cause of death in adolescents. And children are filling up emergency rooms and acute hospital beds with diagnosis of behavioral health and depression and suicidality. For primary care providers caring for adolescent, treatment options are limited. The primary care providers are not just the quarterbacks, but they're also the blockers and tacklers in this epidemic of behavioral health and depression in adolescents. They are being called upon not just to screen for depression, which is an ever increasing prevalence, but they're also called upon to provide care in their office because there aren't enough mental health providers to address the increasing demand. Additionally, and I'm just sharing with you the guidelines for adolescent depression in primary care, discussing how primary care providers and pediatricians have become, and family health providers have become the de facto treatment locations for these adolescents. There's an increased need for primary care providers to offer behavioral health services, and that includes supportive counseling, psychoeducational support, referral for peer support, facilitating parents and patients self-management, and monitoring for depressive symptoms and suicidality. But children are not little adults, and so what works for the adults doesn't work for the children. Children and adolescents have specifically, and we have a teen advisory council that we work very closely with, and they have told us they want something autonomous, they want something discrete. They don't like to be there face-to-face. They like to do it on their own time and at their own convenience. And they want it to not disrupt their daily activities. These kids are in school, they're doing sports, they want to be with their friends. They don't want to spend a day in a doctor's office talking about their depression. And one of the main ingredients for adolescent depression treatment is behavioral activation, which is part of cognitive behavioral therapy. So at SparkRx, which is our product for treating depression in adolescents, we use behavioral activation as the active ingredient in our digital therapeutic product. It gives mood tracking, problem solving, weekly assessments, mindfulness, activity scheduling, and psychoeducational opportunities for the children to participate in. There are several key features. I know we don't have a lot of time. They are able to do weekly PHQ or patient health questionnaires to monitor their progress. They have interactive tests and awards, and there are safety built-in safety features.
That's great.
Just real quick, just the data has shown that we have reduced in a clinically meaningful way symptoms of depression by at least 5 points in those that participated in the use of the app. And when compared to a control app, we showed a 21% remission rate in kids who used the app versus 4% who used the.
All right, Ben, that's great. This is, look, I know coming from a family and all families, we all need this. So thank you guys. And this is definitely an extension of primary care. Thank you, thank you. Hitesh, let's hear about Onliv Health.
Hi guys, so thanks for having me. You might have heard from Dr. Perler in the day. So Onliv is all about, we're in the early stage, stealth mode, but super excited. With Onliv, we are solving two key problems of primary healthcare. One is how do we deliver the experience, the whole person experience, and how do we do that in a very economically viable way so that it's not just meant for a small minority of population, but for broad patient population. So let me tell you a story of my friend. My friend has type 2 diabetes, elevated blood pressure, and her father had a heart bypass surgery in late 40s. So she is very particular about her health, tracks all her vitals, eats healthy. But she is frustrated with her primary care experience. She is concerned because she has more questions than answers. She is concerned because she needs access to a cardiologist and endocrinologist to understand her risk for heart attack. She is concerned because she's grappling with her daily concerns while she gets a care support once in 3 months, if at all she gets. And that's pretty much a classic case of where the primary care is failing as being the chassis, being the foundation for those who have any health condition. Now, my friend could pretty much, hire a concierge doctor who could pretty much answer any questions she might have, and she could consult with a endocrinologist or a cardiologist, maybe once a year, once in, 6 months, but that's going to be expensive. And more importantly, it may not be even, result in better health outcomes. And that's really how we're trying to solve it. And how do we do that is we start with a virtual first care delivery model, and we do 3 key things. First, we deeply integrate specialty care. So in case of my friend, not only her primary care doctor, but a cardiologist and endocrinologist would be reviewing the same medical record data and would be able to advise her proactively versus she trying to reach out. Number 2, we increase care resources by 5 times, both to patient and to the physician. So in that case, in my friend's case, she would have someone who will curate all the data, provide the insights to the doctor. So the doctor is now ready to answer any questions she might have on an ongoing basis. And the third is to really power it with a purpose-built care operating system that does 3 things. It does intelligent care orchestration. 2, it provides the digital health tools, both for the patient from remote monitoring to digital therapeutics, and then to the physician, it provides clinical decision supports.
Okay.
And when you do that, you're essentially building a chassis. And in some ways, it's essentially taking the experience that Dr. Paul had at Kaiser and kind of leapfrogging it, both in terms of the economics and both in terms of the scale.
Okay, great. And Hitesh, is your product in market or are you in development right now?
So we are in development. We are launching it with a clinic, 4,000 patients early next year, and in conversations with few healthcare systems as we kind of deploy it at scale.
Great, excellent. Hubert, I'm going to let her rip. What questions do you have?
Already done. All right. Hey, first, Andy, I'd love to learn a little bit. I mean, it sounds like a really great idea, the crowdsourced insurance. But insurance companies have been around for a long time, stratifying the risk, reinsurance. We could go a couple of days nonstop on this topic. So how do you, what's your immediate, your obviously this is probably going to be the first question you usually get asked. So what's your immediate kind of answer to that? How does this possibly work?
Yeah, so ultimately we're just trying to lower the price of each one of these individual procedures, and we think that by paying doctors cash at the point of sale, they'll be willing to give us a significant discount when compared to health plans. I mean, we heard in the last panel just doctor burnout, and the number one cited reason for that is dealing with health insurance plans, the administrative cost of doing that. Doctors spend about 30% of their time dealing with health insurance plans. And so if we can eliminate that and make it cash at the point of sale, as opposed to waiting 60 or 90 days, what we're seeing is 30 to 40% discounts versus what your health plan will pay. So that is the primary source of the savings, but the administrative cost savings are there as well. And so that's how we're operating.
So that's 30-40% below what the plans would pay. So this is in addition to the discounts off of the rack rate.
Yes, this is 30 or 40% off what plans actually pay, not rack rate. Got it.
And since you're private pay, you can do that. But that doesn't answer the question on the risk stratification. Who do you let in? And a couple of bad, when you're small enough, a couple of bad cases could
just takes one.
Yeah, no, it actually really doesn't, because the interesting thing about our concept here is that we will treat this like any other large health or any other health big expense that we have in our life. So let's just take, for example, real true life example, cardiac arrest, went in Fortunately, the guy survived. $500,000 hospital bill that was post-negotiated to about $100,000. It was financed over 2 years, so it was $4,000 a month for 2 years for a cardiac arrest patient. If you can just say you have a very small number, let's say 2,000 members, that's $2 per member per month for 2 years to pay for that very large catastrophic event. So those large events, and actually, we think that 30 to 40% of what people pay in on a monthly basis will be for those large catastrophic events. So it takes, probably, hundreds of catastrophic events for us to have, serious financial issues.
Right. Ryan.
Yeah, I don't want to just pick on Andy, but I've got to ask the question. So do you think about this as like a reciprocal model in insurance? So I'm kind of cursed by some experience in the insurance industry. Is that how you think about this, where the members are essentially then co-insuring through these contributions?
Yeah, we don't use insurance just for regulatory reasons. It's not insurance. It is, you're truly, paying for your own healthcare. There's a community of folks. Think of a GoFundMe for health insurance exclusively, that in the background will help you with some of these big expenses, and it is on a reciprocity type of situation. So we're adding a score, if you will, a generosity score to the platform, so that if you have a person on the platform that never gives or never says yes to that request to fund, their score is impacted by that, and therefore they'll be less likely, if they have a big event, to get funded by others. So there is a law of reciprocity here that does drive the engine on the back end.
Great, thank you.
Okay, great.
Mark, may I ask Benjamin a question?
All you?
Great. Benjamin, I'm intrigued by your company's approach to mental health. And we have actually a similar company that may be compatible with what you do, called Clarigent, that works in suicide ideation and identifying that risk. So that could be interesting to talk about. But I'm interested to talk about kind of how you're going to market and building awareness for your digital therapeutic approach to mental health.
We're targeting directly to providers to have them start using SparkRx with their patients. They receive a unique access code. And so if they see a child in their office and they do a screening questionnaire for depression and they identify symptoms of depression, they're able to right there in the office have the child download the app, enter the provider's unique access code, and start using right there. We're also approaching health plans to look at unique unique payment programs and licensing programs to be able to incorporate into population health models. We have a fee, not to get on the fee for service thing and all that, but we have a broken fee for service model, right? And what would be great is to really create an environment where there are bundled services, and it can be part of a bundled behavioral health service, so that when you identify depression in an adolescent, they're not getting splintered care and they're going to this provider. It's all being bundled as a single entity that is a solution in a population health solution.
Right. David, all you.
Yeah, I'll try and open it up a little broader. I think just given the quarterback here in this situation is getting blitzed from all directions, and there's a poor offensive line, and to expand upon the analogy a bit, or the play caller, Nick, in what you referenced. Laura, I'll start with you. How do you change, good form, Hubert, how do you change the business model to enable that care to be taken care of? I know cardiovascular conditions are a big issue, along with what you're trying to address in osteoporosis and bone health and neuro conditions, particularly for women. But beyond that, behavioral health in the primary care market, how do you expand, get the time and attention of the primary care, the quarterback that's being blitzed from all directions, and fit within the business model that varies from fee for service and value-based care? So Laura, if you don't mind, and then those on the panel, anybody else that wants to add?
Well, I think the first step is to design the intervention to be very lightweight and not tax primary care. So for instance, I expect that if a patient has trouble using our device, they call us. They shouldn't have to call the doctor. The doctor diagnosed them, but we can support them through that journey. Also, it's interesting, CMS has put out for comment a code for remote therapeutic monitoring. So doctors actually can get reimbursed, or this is the proposal, and it's for musculoskeletal and respiratory. Doctors can get reimbursed for the time that they spend working with patients on the device, for dispensing, for training. So I think there's trying to be a recognition that doctors can't do this for free.
And Laura, follow up on that same question. Do you have plans of like working directly with primary care physicians or health plans, or what's your go-to market at this point?
Yeah.
And if you do work with providers, what's your plan on training them? Because they need training before they can give training.
Yeah, so it's an interesting challenge for startups who believe that primary care will be the primary prescriber to how do you reach those doctors, right? There's hundreds of thousands, and I certainly, can't raise enough capital to hire sales department. So we have really a two-pronged strategy. One is to do one-to-many marketing. Our device is very low risk. We think it should be pretty easy to train people on it. And so there'll be more of like, webinars, publications. So if our pivotal trial works out well, we think that this will allow us to publish on this. And this is primarily how doctors learn about that. Frankly, they don't want salespeople calling on them, even if they were allowed to anymore. But in terms of demand generation, we do plan to reach out directly to patients, because our demographic of patient is actively seeking safe and effective treatments. So we've done some testing. We know we can reach them efficiently where they are on Facebook, online, doing their research. So kind of going at two levels.
Okay.
And where we come into that as HeyRenee is we really see ourselves as the integrator and aggregator across the ecosystem, not to overwhelm the patient with a bunch of options, but let's say a doctor tells a patient they're at risk for osteoporosis, or they have osteoporosis. Great. We would look at their insurance, find out that Laura's product is covered, make sure the patient gets it, does a single sign-on, knows about it, and make sure that the doctor knows the patient is using it and that the patient knows how to use it. Similarly, for a myriad point solutions, our view is, last week I went to the doctor myself for my annual physical, my own personal doctor, and she said to me that I need to do a sleep study for sleep apnea. To do that at UCLA Health requires us to fill out an 11-page form that most people will not print or figure out how to fill out. And then you get this gizmo at your house that requires some degree of tech savvy to figure out how to connect and hook up. The PCP should be able to say, get a sleep apnea test and know that someone's there to help the patient do that, or to get transportation to the doctor's office, or to fill the prescription with the generic, or to use a point solution like Hinge Health, or the gentleman Limbix, who was talking about teen mental health, which is such an important issue, or osteoporosis or cardiac health. They're all great solutions. And we want to be the quarterback that brings them together based on the doctor's play calling, makes them all work together on behalf of the patient by building a patient-centric and patient-friendly interface and platform.
Nick, you actually said that really well. And I think you're right. Wouldn't it be great if there was RPM for everything? There was a device or two or three. So instead of the doctor having to be expert, he's sort of go to the device, then let's talk, which is effectively what you're suggesting. That's great.
And just to add to that, where we take it is, the health outcomes is not just making sure that the referral happens, whether to a Hinge Health, whether to a osteoporosis device. What you really need to happen as part of effective primary care is continuous evaluation whether that particular intervention is really working or not working. And so the way we kind of look at this thing is, as part of a chassis, is yes, you provide the resources to decide what intervention is needed, but then more importantly, provide a means to close the loop to see whether that intervention is working or not working for whatever multiple reasons. And if it's not working, what next? Because ultimately, every decision has an economic impact. And if you're not measuring it real time, you can't make those decisions and it kind of percolates down the road.
Yeah. Yeah. And Mark, I mean, you playing to that at Devoted. I mean, that's what you guys are, that's a lot of your thinking with your smart bots, right?
Yeah, well, at Decoded, I think it comes down to even, before that, which is this all begins with a patient and a physician connecting with one another. And what we see at a lot of the clinics that we're coming into is that clinics will have maybe 100 to 150 open available appointments or time slots during the day. All of those will be taken up before the day even starts, and they'll get 50 to 70% additional patients walking through the door. And so how do you even begin to provide a quality healthcare experience when you're starting to rationalize a 15-minute encounter down to 5 minutes because you've got twice as much capacity, twice as much demand as you've got capacity for? And so as we start to think about that, how do we enable physicians to start to leverage some of the technology that automates a lot of what they do that's maybe repetitive, but requires clinical knowledge, medical expertise in order to do a lot of the patient interview, a lot of the interrogation of past medical notes, so that the physician has a complete data fabric from which to make decisions very efficiently, very effectively.
Yeah, that makes sense. And Rachael, you play to this. So, I mean, I want to hear a little more about HealthNxt. You guys spun out, non-traditional way of going about things. Are you really a product, or are you just a product? You're a front end to professional services. I mean, how do people buy you? But I mean, you're selling a lot of what Mark's selling, but in a very different set of clothes.
Sure. Yeah. So we absolutely are a product. So our platform, the architecture is very modular and flexible. So whenever we think about our customer as a health system and all of the complexities that every different health system organization has, we know that we have to be able to be nimble to meet their needs. So really, we do a tremendous amount of services at the beginning and really all the way through as we go through implementation. And it's really a marriage type of relationship that we end up having with these organizations. We align with what their digital transformation roadmaps looks like from a strategic perspective, and then help them to think about, okay, if you look at all the different vendors that you have implemented across your system, how many of them are repetitive? How many of them are actually potentially in contradiction with one another? And help them to think about, as you're thinking about your patient experience end to end, how are you supporting that so the patient knows at any point in time, this is the tool that I should be using for my osteoporosis. This is the tool that I should be using for my diabetes. This is the tool that I should be using for getting an appointment with my primary care doctor. But it's all in a singular wrapper that makes it very easy for them to access so that they can go through their day. And on the clinical side of the house, while absolutely our CMIO is kind of always the lead in making sure that we're understanding and thinking about the clinical workflow and the clinical implication, but it is not just the physician. We think about the rest of the care team and elevating all of the capabilities of the other members of the care team. So your care managers, your navigators, everybody else, so they can help the patient.
Got it. And Anthony, your product is actually similar, but it just takes a very different approach. Why don't you how about an example or two where Insiteflow?
Speaking of complexities in disparate systems and challenges within EHR.
Yeah, so exactly. So let's pivot off of what Rachael said. So if you're, picking their solution, then they're pulling all that together, and that's great. But often, as we know, the primary care practice, the integrated delivery network, they've already purchased analytics. They've already purchased these other solutions. And so what we do is, rather than making you rip and replace anything you already have, in one click, you can access all of that inside of your EHR, you're single signed on. So let's say you're seeing a Medicare Advantage patient, right? And most of the time you're just billing for an office visit. Well, in Medicare Advantage, you've got to every year actually diagnose all their chronic conditions. And you're not going to typically remember that as a primary care doc. So a notification can come up, remind you of all these chronic conditions. You open the app, and now all the analytics from your vendors, whether it's around risk adjustment, quality measures, medication management, clinical surveillance in one common interface, you're seeing all of that. And then you have the automation to say, yeah, I'm going to do this diagnosis, the ICD-10 code, the documentation, the orders. We write that for the clinician right into the EHR. So they don't have to, remember the right codes. None of these clinicians went to school to be coders or documenters. And so we've really got to make it easier on them. If we just push more data into their EHRs, we're not actually really solving any problems. So this is really, how do we tackle that workflow? How do we really improve that clinician experience?
Now this is all coming together. Ryan, what would you, any other questions?
No, I was going to say, I think that feedback loop is so critical. You know, I was a primary care provider, and when I gave somebody a prescription and they left my office, I had no idea what they were going to do with it. And that's why I think it's so important to have that feedback loop. You know, we're developing a portal and a system for providers to be able to see and track not just the outcomes of the questionnaire results that their patients fill out weekly to see if they're improving, but also engagement. We're actually going to see if they're using the product and if they're using it as intended, which, you know, is not something that exists currently in prescription therapeutics. So imagine giving somebody a primary care provider giving somebody a prescription for something, they get it right there in their office, and they get weekly updates as to whether it's being used and what the results are.
So Ben, question for you actually about that, because if you're getting information back about whether or not something's being used or even the potential efficacy of a therapeutic, for example, are any of those responses that are going back to the patient driven by algorithms, or is it all based on somebody having to look at it and then take the next action?
So the provider will get the results of weekly updates in terms of questionnaires and depression questionnaires, as well as get results of whether the patient is going through the modules as prescribed. And then it will be up to the provider, you know, to reach out to the patient or doing a follow-up visit to review those results with them.
Got it. Okay. Yeah, I think we're also hearing a lot about, you know, the automation component and potentially how can we expand the capabilities of a provider in a day if you can protocolize something and have there be an automated trigger that goes back to that patient to say, hey, you need to fill this out, or hey, you know, things aren't looking so good because it looks like you didn't take your meds, you know, let's get you back on track with some medication adherence. And all of that can be driven through automation. It doesn't have to be a person-to-person interaction.
Yes.
I mean,
Rachael, that's exactly what we're doing at HeyRenee with the AI part of what we're doing, which is everything doesn't have to go back to the provider. If my blood pressure is high and I'm on amlodipine and I haven't recorded taking amlodipine, anyone can, any piece of software can be programmed to say, Nick, maybe you should try to take your amlodipine and let's measure again in 2 hours. And getting that feedback to the provider, hey, this person's taking all their medications and blood pressure is still high, is more valuable than burdening them with every little piece of information, right? And that's the feedback loop is between the patient, their care circle, which is often their family members, and then to the providers when necessary, right? I think that's a really important part of making this all work.
Absolutely.
Ryan, I know you had a question on this too.
Well, it's a variation on the theme. I think it'd be interesting to hear from the companies, you know, being on the front lines and trying to enable and empower the primary care physician better. What threats do you see, or are you hearing from primary care physicians? What are the emergent threats that, you know, your technology can help them, you know, counteract and be responsive to?
I think that there's a unique threat that I'm starting to hear from clinics and in hospital systems. And the threat is around disintermediation from direct to consumer and retail primary care. And so, you know, the consumer expectation, in addition to being set by other consumer products, you know, Apple, Amazon, et cetera, is now being set in healthcare by, you know, companies we've heard from today that provide a really good digital first experience. And so how does a regional hospital modify their infrastructure and their technology stack to be able to deliver at the level of engagement, accessibility, and, you know, digital first experience that some of these direct to consumer startups are starting to deliver in the marketplace? Because, you know, the primary care is really the top of the funnel for many of the revenue generating activities downstream with respect to specialty care, surgery, et cetera, for the hospital. And they're not exactly high margin businesses. So small impacts at the top of the funnel can have real demonstrable impacts in terms of profitability.
And I'll just make a sorry, go ahead, Hitesh.
You know, it's I would just, you know, adding to Mark, this is what we are even hearing from, you know, one of the large, you know, healthcare systems, where as they're kind of trying to be more relevant, they are kind of looking at their business as not just, captive to 20, 30 miles from where they are situated, but kind of looking at the virtual first, digital first as a way to kind of expand their market. So one of the interesting, insights we are seeing is they're looking at, partnering with a virtual first, digital first, value-based primary care healthcare system where they are no more relying on, unnecessary procedures to fill up their hospitals or procedures, but rather kind of expand their market beyond their geographic reach to kind of, really, prevent getting disintermediated by some of these solutions.
Yeah, we actually tracked that in one of our implementations, was the size of the catchment area before and after the implementation of a virtual front door solution that we had implemented for an ER. And you can clearly see that once you implement a virtual front door solution that's able to actually steer patients to the right line of service, both virtually and in clinic, they used to call omni-channel in retail, that the catchment area expands dramatically. Patients come from much farther for geographic areas than they otherwise would have.
Yeah, absolutely, especially with the bundle payments around specific procedures, that kind of allows that to happen a lot more efficiently.
And the only thing I'll add to that real quick is we've talked to hundreds of doctors with us at Heal and at HeyRenee. The number one frustration doctors have is they can't get the patients to do what they asked, which is why we created HeyRenee. The number one fear is right now it's a political, getting attacked from the crazies out there, right? And when they're working so hard. But the number one threat is actually that the largest employer of doctors in America is also the largest insurance company in America. Doctors are losing their independence, and they don't want to because they think it compromises patient care, and they're giving up on the independence because they can't keep up with the bureaucratic and administrative overhead being imposed upon them. Someone said they went to medical school to become doctors, not bureaucrats. That threat causes them to throw in the towel, causes a frustration, say, just go learn computer programming and make a lot more money for a lot less work.
Yep. I think to build on that, where the rubber really meets the road there is if we're just pushing more data into the EHR. So there's all these great solutions we've talked about, and there's all these feedback loops. But in that, 15-minute visit where you just have 3 or 4 minutes with your clinician, they don't have time to search through your EHR and get all the great output and results from all these solutions. So I think that's one really big threat is we're overwhelming them with too much to do. And then here's the other challenge. If each and every one of these great solutions has their own alert and notification and their own button to click on in the EHR, we'll actually take what is already a bad experience and we'll find one of the only ways to make it worse for the clinicians. And so I think this idea of how do we actually curate a better experience for the clinician to get the benefit of all these great solutions that these other entrepreneurs have is really critical to empowering clinicians, when they're really seeing their patients.
I have a question. Do we really believe that the long-term interface for the physician is the EHR? Do we think that there's a headless EHR?
Yeah, so I think the thing to think about is the EHR is going to remain the transaction processor, right? You're not going to get major providers at this point to rip out Epic and Cerner and all these major EHRs. So you're absolutely right. We have to think about ways that we layer on top of those transaction processing systems. But at the end of the day, you've got to tie in to those transactions, right? That's ultimately where the billing is going to flow through. And that's really what we do. We're putting another interface that really is on top of that is more user-friendly, that does empower the clinicians. Absolutely.
So we have a different view. And the view is, if you look at it, there's a secondary care and there's a primary healthcare. Or there's a sick care and healthcare. And each has different objectives. And yes, as you laid out, yes, for transactional, for all the procedural purposes, for the sick care part of it, in secondary care, you need that kind of a layer. I don't think so we need to replace that. But where we see is missing is the primary healthcare, all the way from the workflows, how the primary care is practiced, to the need for a different kind of a health, EHR, almost more like a healthcare CRM, because it's all about a partnership with a consumer on an ongoing basis. And so you really need a different kind of a longitudinal, platform that almost in some ways becomes a system that sometimes becomes a primary care healthcare system, which is literally intelligently care coordinating all the different pieces based on how different stages of person's life. So just so one data point is when we look at, from a workflow point of view, we all know that, I don't think so. We can really reduce the patient panel for an average primary care physician. We just have a shortage of primary care physicians. So the only choice we have is how do we make it a lot more productive, which essentially means is you, especially for chronic and ongoing healthcare, you have to change the paradigm for patient reaching out to a primary care on a every 3-month kind of a visit as part of standard protocol to a clinic reaching out, informed by the data that is getting, and really figuring out when there's a need for an intervention, when there's a need for change of treatment plan. Now, when you do that, it frees up doctors' time to really focus on acute, really focus on care escalation. And so the way we look at our workflow is where our doctors are really almost spending every 6 hours of 8 hours, almost like as urgent care physicians. When the care gets escalated to them, they're pretty much kind of looking at, really diagnosing a specific medical issue. And then when they bring in a specialist, that really kind of allows them to resolve the issue right then there versus kind of pushing the referrals down the stream.
Yep. No, I think this is great. I think we're getting onto something. I mean, all these, the companies are here that we're really engaging. It's all about, we've talked about Amazon. We've basically talked about what happened in e-commerce. I mean, we got to make sure that these primary care physicians and regional hospitals don't become general stores, or they will get Amazon, right? And so we're all basically giving them these approaches, and these approaches allow them to, allow them to play the e-commerce game and not to basically be ostriches, or otherwise it won't end well. And that's a lot of the great stuff we're hearing today. Hubert, I know you got something here.
No, I just wanted to, I know we're coming to a close here too. I just wanted to say just an observation. Number one, I'm a physician by training, but physicians go into medicine because they want to have an impact on people, actual people, not numbers like so many of you said, not EHRs, not billing systems. So yes, you're spot on. What motivates a physician is going to be having an impact on people and seeing that impact. And the same is true of the patient. What motivates a patient is to see that a human being actually gives a rat's ass. And so as you can help physicians, and I didn't say shit, so now I said it anyway. As you can achieve that and allow, and I think your thinking is well aligned, because the biggest motivator for patient too, and I count myself amongst those, if I really feel like my physician cares about what it is that he or she prescribes and makes me do or tells me, then I am motivated. That explains all personal trainers in the whole world. So there is that human element that I think all of you are acknowledging. At the same time, you're looking all for great solutions to help those physicians find that true north that allows them to be effective. And if we can accomplish that, I'm really excited. So I see a lot of great approaches here, and I'm glad I'm on that panel to hear from you guys.
Yeah, no, I echo that. David, Ryan, before I wrap it up, what other thoughts do you guys have?
Yeah, I'm happy to ask a quick question of the group, and apologies for my mic and the muffling. Anthony, I was agreeing in the complexity of what you're trying to solve as well, but maybe since launching your adventures here, what's been the unanticipated surprise or learning quickly, if you will, on the benefit, on the good side from the company?
Yeah, that I think primarily the willingness and the actually being excited of the actual member to be the quarterback. I think we tend to push the responsibilities to the primary care physician. We tend to push the responsibilities to the doctors, but if the responsibility ultimately falls with the patient, and the patient is the one that needs to take the steps necessary to improve their healthcare, what we're seeing is the patients are willing to do that. Yeah, they need some coaches on the sideline to help them call the right plays, but I think there is an absolute desire and a willingness to be coached in doing that and being responsible ultimately for their healthcare. So behavior change is difficult. That's one of the most difficult things in the world when you're starting a new company, but it has been pretty impactful.
Agreed. Ryan, any parting thoughts?
No, I think it's just really great to hear what these entrepreneurs are leading with their startups. I think they're all well positioned to make a very positive impact.
Yeah, no, guys, I agree. I mean, what we heard, Hubert, I think you said it really well. Look, at the end of the day, more drugs are being prescribed by the local pharmacists than they are being by Amazon or GoodRx. And we do need, everyone wants a person. We want basically someone we trust. And if we're all, and that's what all of you companies are really in the business of doing, is basically allowing these primary care physicians, practices, everyone out there to be able to play the Amazon game, but on their terms. And doing it really well. And really with that, Bambi, I'm going to hand it baton back to you.
Right. Well, I have nothing more to add because I've been already speaking for about 3 hours. So I think you all know my thoughts already, but I really appreciate, Mark, you shepherding this to the end. And thank you, all of you guys, for what you're doing, and the VCs for coming in and trying to ask some great questions as well to really bring out the essence of these companies. So thank you for that. Really quickly, we will have videos up of these panels. We'll also have write-ups. And if anybody wants to get in touch with these speakers or anyone, you can email hello@vader.tv. And I will make sure that I can make that connection. So with that, it's already 4 o'clock PT, my time. I don't know where everybody else is, but we've been on for about 4 or 5 hours. I've lost count. So thank you. And hopefully you guys can and create some partnerships.
Absolutely. Thank you, Bambi.
Thanks, everyone.
See you guys.
All right, here we go.
Take care.